Good morning to everybody. We are beginning plenary session 1. I'll request you to kindly take your seats, please. Thank you. Welcome back to the auditorium. Welcome to plenary session 1. My name is Shekhar Saxena. I work for the Harvard School of Public Health, and I have the privilege and pleasure of moderating the plenary session 1. What's the session about? It's about provision of health and social care to ensure healthier and longer lives for people with severe mental illness, the very substance of this entire conference. We will have 3 segments to this session. The first one will be a presentation. The second one will be the launch of the WHO guidelines. And the third will be a panel. We have some distinguished panelists here who will answer questions and lead the discussion, which I hope all of you are able to join. So it's very much an interactive session. We had 90 minutes from 10:30. And we will make sure, along with you, that we make the best use of this time. So it's my distinct pleasure and privilege to be here and to be hosted by Fountain House. I have known Fountain House for some years, and I'm really very happy that they're taking a lead in this, along with other partners, which includes Global Mental Health Program of the Columbia University, which is also a WHO Collaborating Center, Grand Challenges Canada, and Cities Rise, and very much supported by WHO as a technical agency. And the combination of these agencies really puts very nice, not only technical expertise, but a group of people who are passionate about it and are happy to do what it takes to ensure healthier and longer lives of people with severe mental illness. I would be now inviting our first speaker. Her name is Elinore McCance-Katz. She is Assistant Secretary to Mental Health and Substance Abuse and advises the Secretary for Health and Human Services of USA in improving behavioral health care in America and leads the agency, the federal agency called SAMHSA, which is a huge agency with huge responsibilities. But what's very interesting is that Eleanor has been a clinician, has been a teacher, and has been a researcher. So she's just not head of an official federal agency, but she brings a wealth of experience from her past to be able to lead USA into better mental health and substance use services. She will be speaking about addressing healthcare needs of those living with severe mental illness. Eleanor, the floor is yours.
Well, good morning, and I just want to say how happy I am to be able to be here with you this morning to talk about the importance of providing physical health care to people living with serious mental illness and substance use disorders. And I'm especially happy to be here because I know the World Health Organization has published a guidance on addressing physical health care needs of people living with serious mental illness and has made recommendations for ongoing evaluation and addressing medical needs of people living with serious mental health conditions. It's very important to us in the United States at the Department of Health and Human Services and the Substance Abuse and Mental Health Services Administration because these kinds of documents help us to move the agenda forward that we think is so important for helping people that live with these conditions. We endorse this as a priority area, and we have funded programs to assure that these needs are being met. We'd like to expand them even more, and so these kinds of conferences, these kinds of guidelines help us in those goals. And I'll talk to you for a couple of minutes about what we're doing at HHS, the Department of Health and Human Services, to address these issues. But first, let me just say a couple of words about mental and substance use disorders in the United States. This is data from the National Survey on Drug Use and Health. The latest data that we have is from 2017. And what it tells us is that nearly 19% of American adults have a mental disorder, have had a mental disorder in 2017. Oh, you see the whole presentation. All right, I hope you like it. Right here, from current slide. There you go. All right, so this is nearly 47 million people. When we look at that in a little more detail, we see that 24% of them had a serious mental illnesses that impair people's ability to live healthy and productive lives. When we look at the substance use disorder side, we see that 7.6% or 18.7 million Americans over the age of 18 had a substance use disorder, 75% related to alcohol problems, 36% related to illicit drug use disorders, and 11.5% who had both an alcohol and an illicit drug use disorder. And we have a large number of Americans who have what we call co-occurring disorders. So simultaneous experience of a substance use disorder and a mental illness, 8.5 million Americans. And this is really very important. I want to show you a little more data on co-occurring issues because co-occurring disorders, co-occurring substance issues are quite common in people that are living with mental health conditions. What this data shows you is that the orange bars are the general public, people without mental illnesses. The blue bars, people with any mental illness, and the green bars, serious mental illness. And what you see is that for people with mental illnesses, the use of substances is significantly greater. It includes cigarettes, daily cigarette use, binge use of alcohol, illicit drugs, marijuana, opioid misuse, including prescription pain reliever misuse, as well as heroin misuse. And these kinds of co-occurring problems put people at even greater risk of physical health problems, which really compounds the kinds of burdens that they are living with on a day-to-day basis. And mental illnesses really represent some of the major challenges of our time. We're becoming more aware of this as a society. That's a good thing. We know that over 11 million Americans are living with serious mental illness. 33% of them got absolutely no care or treatment for their mental illness. Unfortunately, our jails and prisons have become de facto mental institutions. 2 million people are incarcerated in the United States every year. 20% of them have serious mental illness. 50% have a substance use disorder, and only a third of them will get any kind of recognition of those conditions and care. This creates a revolving door of disability for people affected by these conditions and makes it quite likely that they will have difficulty with stable housing, difficulty getting employed, and they lack the ability so often to live healthy and productive lives because they are not getting the resources that they should be getting in this country. That leads to higher rates of suicide. If we look at people with serious depression and psychotic disorders, they have rates of suicide that are 25 times that of the general population. We also see that for people with untreated or poorly treated serious mental illness, they have higher rates of physical illnesses that become more difficult to treat over time. And this translates into a reduced life. Depending on the study that you look at, you will find that people with serious mental illness have between a 7 and 32 year less number of years to live than the general public. So this is a huge, huge burden for people living with these conditions. So why is it? Why is it that people with serious mental illness receive less physical health care? We have systemic issues in the United States that we must address more effectively. We have too much physical separation of mental health services from other medical services. We still have insurance plans that carve out mental health treatment of substance use disorders, and make it much more difficult for people with co-occurring conditions to get the care and treatment that they need. Healthcare provider attitudes sometimes can be a barrier, and often healthcare providers will lack experience working with people who have serious mental health conditions. And people with serious mental health conditions, substance use disorders, too often experience poverty, and poverty is a barrier to getting the care and treatment that they need for these conditions. People living with serious mental illness receive lower rates of screening for a number of different types of physical health conditions. Two of the most common in our society, diabetes and cardiovascular disease. It's well known that people with serious mental illness are much less likely to be screened for these conditions and to get treatment for those conditions. And metabolic syndromes, those syndromes that occur as a result of the medications that we may need to use to treat a serious mental illness, produce serious physical illnesses if not attended to clinically. And so these are areas of risk and vulnerability that we can and must address. Medical illnesses occur at high rates in serious mental illness. We know that the seriously mentally ill are at higher risk for chronic physical health conditions. They too often have poor diets. They have side effects of psychotropic medications. They lack access to primary care. We also know from research that people with schizophrenia and major depression have much higher rates of diabetes than the general population. People with bipolar disorder and major depression, much higher rates of hypertension than the general population. Well documented. And so we know at the Substance Abuse and Mental Health Services Administration, we know that there are great needs for those individuals that we are charged with helping. For people living with serious mental illness, we want treatment and community recovery services. It's not enough to just provide medical and psychiatric care. We must have community recovery services available to people. We want continuums of care to make necessary resources available to the seriously mentally ill, not just inpatient treatment. The vast, vast majority of people living with serious mental illnesses do not need to be in a hospital. They do not need to be institutionalized. What they need is access to resources in the community. And so it is not enough to have limited outpatient services. We must have a continuum of care that includes partial hospitals, intensive outpatient treatment, assisted outpatient treatment, assertive community treatment, and supported living situations, because everybody's needs are different, and we should be able to meet all the needs of our people. We want collaborative care to best serve those that are living with these conditions. We want partnerships between the psychiatric and medical communities and the recovery support community. In my opinion, there is not enough communication between these groups, and we need to improve on that. And we want partnerships with key stakeholders, such as those of you who are here today, that can help us to address the needs of Americans living with these conditions and help us to prepare our workforce and bring more people into the healthcare workforce who will learn about and treat these conditions. So why should we do this? Because mental health is key to physical health. A person has to be able to access mental health care if they have a serious mental illness, and in doing so, that will help them to take on those additional needs they have and seek physical health care. But we have to make these resources available, and we must make it easy. It has to be easy. It is not easy in this country to access mental health care, physical health care, substance use disorder care when those things are needed by an individual. And so at SAMHSA, we think about this as an issue of integration. We believe that integrated services are going to be the way that we will move this forward and make it easier for people to get the care and treatment they need. We know that 70% of people who live with a significant mental or substance use disorder have at least one chronic health condition, 45% have two, and 30% have three or more physical health needs. 75% of people who commit suicide have contact with a primary care provider within the year of their death, and 45% within the month before they die. We need to do a much better job of screening and providing care and treatment to people who have suicidal thoughts. 70% of primary care visits are related to psychosocial issues, but often people are reluctant to discuss them with their primary care providers, and yet we know that primary care providers prescribe 75% of the psychotropic medications in this country. And so we have a big opportunity to address behavioral health issues by integrating mental and substance use disorder care and physical health care. And I'll tell you how we're doing that at SAMHSA. But first, I'll just tell you that part of how we think about this is we know there is a big mismatch in the United States right now in terms of what people need. If you look at the physical health sector, you see that 75% of people with mental and substance use disorders will be seen in the physical health sector. Less than 5% of practicing behavioral health specialists work in that area. In the behavioral health sector, 25% of people living with mental and substance use disorders are seen, and that's where 95% of the workforce that specializes in behavioral health provide services, and less than 1% of the clinicians in behavioral health settings provide primary care services. So big mismatch. And so what we have done is we've developed over the last few years a couple of different types of programs that have been demonstration programs to date, but I'll show you some data that shows that these are very positive kinds of programs for people living with these complicated conditions. The first is primary and behavioral healthcare integration, that we call it PBHCI. And then we also have a new program called the Certified Community Behavioral Health Clinics. We also work collaboratively with our colleagues in primary care to train on how to recognize and treat substance use disorders and mental disorders in primary care settings. SAMHSA has put in place new practitioner training resources. We have new mental health technology transfer centers. We have a new clinical support system for serious mental illness, and we have data waiver programs. That is the waiver that a clinician needs to get in order to provide buprenorphine treatment of opioid use disorder from an office-based practice. These resources we use to train our existing workforce to make them more ready and willing to provide the care and services that people need who are living with mental and substance use disorders. When we look at our population that we included in our PBHCI program, we looked at various types of medical problems that people were experiencing. And what we found was that this program, which was based in mental health programs and brought primary care in, so these are people who were being seen primarily for a mental health issue. They had twice the rate of diabetes, 3 times the rate of high cholesterol, twice the rate of hypertension, and triple the rate of smoking as compared to the general public. When they were able to access integrated care through this program, we saw improvements in a variety of areas, decreases in metabolic syndrome, decreases in obesity, decreases in uncontrolled diabetes and dyslipidemia, reductions in blood pressure, and even reductions in tobacco use. I'd like to see that be a lot better than it is, but it's important that we are starting to focus on this as an issue, and we are seeing improvements by integrating care. And people tell us that they like these services. So people who participated in this program told us that they felt more healthy. They felt they were functioning better in their lives. Their housing was more stable. They felt more socially connected, and their rates of severe psychological distress decreased. So people like being able to get all the services they need in a single setting. And so now we've moved on to what we call the Certified Community Behavioral Health Clinics program. This is a demonstration program under a law Congress passed a couple of years ago called the Excellence in Mental Health Act. And this is a program that requires community-based mental health programs to integrate substance use disorder care and physical health care into that setting. The nice thing about this program, and for me, this is a very key thing, is that this program uses a Medicaid prospective payment system. What that means is that we get the actual costs of care. And so we can enrich services for people who have complex needs. And we don't have data on this yet. We expect to have it soon, but we've had some preliminary reports which have been universally positive. This is well accepted by people who are living with these conditions, and they are able to attract more clinicians to work in these settings, because when you get paid for the services you provide, then you have a situation where you can actually attract staff, which too often is not the case in various organizations in this country. The CCBHCs have to provide 9 different types of services. One is crisis mental health and addiction services. 24/7, they must provide crisis intervention. We don't want people with mental health conditions who are experiencing some kind of exacerbation of symptoms to be stuck in emergency departments. We know that if they can get care that is focused on their needs, that is provided through these CCBHCs, we have a much better chance of keeping them out of the hospital. Screening, assessment, and diagnosis must be services offered. Person and family-centered treatment planning, outpatient primary care screening, monitoring of health indicators, case management, psychiatric rehabilitation services, peer supports, counselor services, family supports. We have to support our families. Families do the most care for all of these folks. Intensive community-based mental health care is being focused also on a very high-need population in our country, which is our service members, veterans, and individuals that are living in rural areas. And so this program is providing integrated services right now in 8 states. We have been fortunate enough to get increases in funding from Congress and the President, and we will be expanding these programs last year and in the coming year. So at SAMHSA, we're going to continue to focus on health and wellness for people living with serious mental illness. This is a major focus for us. We want to address all the health needs of people living with these conditions, psychiatric, medical, and recovery services, including peers, including community resources that focus on the needs of people living in communities, social inclusion, education needs, employment needs, and housing. And for those receiving psychotropic medications, and this is something that I push this very hard. I'm a psychiatrist. I believe that in psychiatry, we are doctors and we must provide screening for metabolic syndrome and treatment. We can do that and we must do it. We cannot have people go to mental health facilities and not get those physical health needs met. So you will see SAMHSA focusing on this. We have a clinical support system for serious mental illness. One component of it requires that psychiatrists and other mental health professionals be trained on these facets of care, because these metabolic syndromes are far too common in people living with serious mental illness. So we will be working on that in an ongoing fashion. We will continue to try to encourage practitioners to get more training on this, and we'll work with individuals and their families to tell them about how they can access services. We think it's important to empower people. That will be a focus of SAMHSA, and I look forward to continuing that work. Thank you very much.
Thank you very much, Dr. McCance-Katz, for explaining to us the state of the problem in this country, but also some of the initiatives that SAMHSA is taking forward to make the situation better. We come now to the second segment of this session, which is from WHO, and they will be launching the formal guidelines that they have worked on for quite some time now. I should, as a way of introduction, say that the collaboration between Fountain House and WHO is now about 4 years old. It has been extremely productive collaboration. It is at a technical level as well as at a financial level, and together this has produced a number of products which are very useful for all the countries, including USA, for example. It has prepared an expert group, it has had meetings, it has prepared a very nice report along with some publications, and also a policy brief which was disseminated earlier. And so the production of these guidelines is another landmark of this collaboration. It's very appropriate that WHO has decided to launch these guidelines in Fountain House in this event, because that is very much a joint effort. And this is really something that will be extremely useful for all countries, at a policy as well as at a practice level. I would like to thank Fountain House for this collaboration, as well as the funders of Fountain House, which, as we know from this morning, includes the Stead Family Foundation, Sydney R. Bear Jr. Foundation, as well as Doughton Family Foundation. So thank you for supporting this work. Thank you for making us reach where we are at this point of time. For the WHO part of this session, we have two presentations. Dr. Tedros, the Director General of WHO, wanted to be here with us today, but unfortunately he cannot be. So he sent his greetings by video, which will be projected now, followed by a technical presentation by Dr. Tarun Dua, who is the Program Manager for the Department of Mental Health and Substance Abuse, based in Geneva, who has led the work which will be now presented as a guideline, WHO guidelines on the management of physical health conditions in people with severe mental disorders. So first the video, and then Dr. Dua.
Excellencies, distinguished guests, colleagues, and friends, greetings from Geneva, and thank you for the invitation to speak to you today, and I'm really sorry I can't be with you in New York. We all know someone affected by a mental disorder. 1 in 4 people are affected. Stigma, neglect, and discrimination prevent nearly 2/3 of those people from seeking help. People with severe mental disorders die 10 to 20 years earlier than the general population. The majority of these premature deaths are due to physical health conditions. We must put an end to this disparity. Universal health coverage is WHO's top priority. All people have the right to affordable quality health services where and when they need them without facing financial hardship. To make health services for mental illness universal, we need to design people-centered services based in communities. Today, we're launching guidelines and best practices that, if followed, will extend and improve the quality of life for people living with serious mental illness. We urge countries to follow them because we all deserve the same chance at living a longer, healthier life. I wish you well in your discussions towards a fairer, safer, and healthier world. I thank you.
Good morning, everybody. I joined Dr. Tedros in thanking the organizers of this conference to inviting the WHO to make the presentation and launch the guidelines. I joined Shekhar in thanking Fountain House for the collaboration. It has been a pleasure and privilege to work with Fountain House in the area of serious mental illnesses. I thank Ken, Ralph, Jeff for the collaboration over the last 4 years, and hoping to be working for many, many more years in this area. So I'm going to present these guidelines, and I have 7 minutes and to present the work done in a couple of years. Let me see how much justice I can do, but otherwise I would be available to answer any questions that you might have. Eleanor, did a great job and set the scene for me of describing the needs that are existing in United States of America. So if I have to think in terms of global needs, I think just multiply things by 5, 10, 20, whatever, wherever you are living in, because the burden is higher in low and middle income countries and the resources are limited. So the gap is extremely huge. So for example, some of the numbers that if we think about the serious mental illnesses, 200 million, that's huge. And if we think in terms of the burden that is due to serious mental illnesses overall, that's quite a bit that is happening across the world. And we know in terms of what are the determinants, disease, and the consequences. And the comorbidity, Eleanor talked about it earlier. But also, I wanted to bring in the impact that is happening at an individual level, impact that is happening at the societal level, and the impact that is happening at a country level. So in terms of, for example, at individual level, the stigma and discrimination that happens, human rights violation that happens for people with serious mental illnesses, and all these things are compounded by if there are comorbidities. And in terms of the economic impact, and I'm sure there are economists, I know there are some sitting in this room, who can tell us the enhanced the cost that is happening because of these comorbidities. We are here because we also know that the physical health conditions lead to excess mortality, and I think this is unacceptable. If people are dying 10 to 20 years earlier, there is that reduction in life expectancy. In this age and era, this is unacceptable. Most of these studies have been conducted in high-income settings, but if we look at, for example, studies that are, have been carried out in low and middle-income countries, they are very high. And Dr. Fekadu from Ethiopia is here and has been leading the work that is happening in documenting those high rates of mortality in low-income settings. And this issue raises the disparities and inequities that are here. And if we are thinking about the achievement of SDGs, we need to address those inequities. And I think this is where the concept of leaving no one behind. And sometimes what happens is when we think about these programs, people with serious conditions, people actually who need more services are left behind. They are not given the services. They are not being provided the interventions that are required. And there is a lot that can be done because many of these things are preventable. They can be prevented, they can be diagnosed and detected early, and they can be managed. So for example, if we looking at the numbers, 8 million excess deaths are attributable to mental disorders. And if we think in terms of the 2 million excess deaths due to NCDs such as cardiovascular disease, pulmonary disease, and diabetes, many of these deaths are actually preventable. So that means our systems are failing, our health services are failing, our care providers are failing to provide that. And so this is why we started to work on these guidelines, and these guidelines are part of the mental health action plan. Shekhar mentioned about a consultation and the article in the World Psychiatry, but also there has been also some work happening through our regional offices. For example, there was a report from our European office, as well as with Gulbenkian Foundation, there was a paper on the comorbidities. And I think this is extremely important to look at the lens of mental health from the lens of comorbidities, because we are within the SDG era thinking about universal health coverage. And in universal health coverage, we cannot think about having the silos. So, okay, you have diabetes, you come today. You have hypertension, you have to come tomorrow. Or you have mental health problem, okay, you need to come on Fridays. So I don't think that's the way we can achieve the universal health coverage as envisioned within the current era. And so with these objectives in mind, WHO started this process of guidelines, and these guidelines are specifically targeted towards the healthcare providers, including both primary healthcare providers and secondary healthcare providers, as well as the policymakers, healthcare planners, and program managers. And sometimes in WHO, we have products that are focused specifically on low and middle income countries, but these guidelines, as you have you could see from the presentation by Eleanor, these are applicable across the world. Now, what is a WHO guideline? I think I thought maybe just explain a little bit. And the reason is that these are the recommendations that are provided following a very rigorous process, and I'm going to describe that process, that helps in making informed decision at policy level. Okay, what kind of policies or plans are required? At service delivery level, thinking of what could be the health systems approach that needs to be taken as well as a healthcare provider level. For example, what a doctor should be doing, what a nurse should be doing. And this helps to prioritize across a range of potential interventions. And as I mentioned, there's a very systematic process that is followed. So it starts with having a guideline development group, scoping the process, and then developing the evidence profiles based on a rigorous systematic review, using the GRADE methodology to tell us what is the quality of evidence, strength of evidence. But evidence is not the only thing that goes into these guideline processes. It looks at values, preferences, feasibility. So for example, X intervention is maybe more feasible in some settings. And so there is a higher value that is given to such an intervention. It looks at values and preferences. And especially in these type of guidelines, where we are thinking about people with serious mental illnesses, what are the kind of interventions that they would value? So it's not only about the values that as a policymaker or a healthcare provider we think about, but it is also the values that people think about. So nothing for people with serious mental illnesses without involving them in the processes to come out these recommendations. So as you can see, this was a systematic process, took us a couple of years, and many, many people contributed, and some of them are here. So if you don't mind me asking, may I request people who have been part of either WHO Secretariat as part of the guideline development group, and we have the chair, Graham, here, as guideline development group members, evidence review team, to please stand up. Thank you very much. And there are some who are not here, but and I would especially like to acknowledge my colleague Neerja, who has been working closely with me in these guideline processes. Now, these guidelines were very tricky, and when we started the process about developing these guidelines on comorbidity, we were asked to look at the scope of these guidelines, okay, which conditions we are talking about, looking at all the existing guidelines that are from WHO, and there are many. And I think this is also what it does, is bringing at one place all the relevant guidelines. For example, related to NCDs, related to HIV, tuberculosis, related to physical activity, and so on and so forth. So I think this is also a useful resource for people who want to look at all the relevant guidelines at one place. So we, again, there was a particular scope that we need to keep in mind about these guidelines. So for example, the scope was in terms of the disorders, severe mental disorders. So these were schizophrenia, psychosis, bipolar disorder, and moderate to severe depression. For example, these guidelines, we haven't looked at substance use disorders or dementia or intellectual disabilities, but many of these recommendations are applicable beyond the severe mental disorders. And if in terms of physical health conditions, we looked at some conditions and some risk factors, such as tobacco, weight management, substance use, cardiovascular disease risk factors, diabetes, HIV, AIDS, and other infectious disease. Now, the process included a systematic search of the evidence using the GRADE methodology for reviewing all the evidence, and then looking at the other aspects which I alluded to earlier. carefully examining the balance of benefits and harms, looking at the acceptability and feasibility such as of the lifestyle interventions, and what are the resource implications. For example, treatment of diabetes and hypertension are among the best buys, that is very cost-effective interventions. And based on that, the recommendations were made. So we will hear more about it later in detail from Graham when he describes these guidelines in more detail. But just to say that the evidence that we found was very limited. The research that has been done on these comorbidity is very scarce and very little from low and middle income countries. But based on those, even whatever currently evidence, the guidelines, they came up with recommendations. And so this is an example of one of those recommendations. Some of the recommendations, if the quality of evidence was very low, for example, the lifestyle interventions for weight management in people with these comorbidities. But the guideline committee decided that this is such an important intervention, and the rationale was to make it a strength of recommendation being strong. That means every person with serious mental illnesses should be advised to have a healthy lifestyle. So these are the categories of a strong recommendation, conditional recommendation. So strong recommendation is that a particular recommendation is advised. A conditional recommendation means that this is something that the prescriber needs to discuss with the person who has the problem and then come out with a particular intervention strategy. And then in addition, the guidelines has best practices around drug interactions, the choice of medications based on side effects, and linking very well with the existing guidelines that are around NCDs, HIV, and other areas that have been tackled in these guidelines. So now in terms of the next steps, I think they are very important, that what needs to be done. So it's not about having these guidelines lying on shelves. It's about their evaluation, it's about their adaptation, it's about their implementation. And we look forward to working with all of you in implementing these guidelines. Thank you very much.
Thank you very much, Dr. Dua, for explaining to us the need, the process, and the contents of these guidelines, which, as you very clearly demonstrated, are for the whole world, for every country, whether it's rich or poor, small or large. So we now go to the third segment of the session. And as you can see, the panelists have joined us on the stage. And I'd like to introduce them to you one by one, and then ask the panelists some questions that they have agreed to answer. So we have Professor Graham Thornicroft, Sir Graham Thornicroft, who is Professor of Community Psychiatry at the Institute of Psychiatry, Psychology, and Neurosciences at King's College London. We have Dr. Dorairaj Prabhakaran, Vice President of the Public Health Foundation of India, and also the Director for Center for Chronic Conditions. Second from this side, Dr. Sudipto Chatterjee, who is a psychiatrist and associated with non-governmental organizations, Parivartan, which means change, and also with another organization called Sangat. And he has been researching and assisting in community mental health services, not only in India, where he's based, but in many other countries. Sudipto. We have Ralph Aquila, who's the medical director for Fountain House. This is his home. And also Sydney R. Bear, director of the Sydney R. Bear Center. And he has been involved in research and advising Fountain House and also in practice for a number of years.